Good day, everyone. My name is Bruce Struminger, and it's my pleasure to be the first person to welcome you today to this third session of our One Health COVID-19 series. And I'm going to be going over a few housekeeping items before turning things over to Professor Jonna and Mazet for our initial formal welcome. The first thing I'd like to do is call attention pour les francophones. Il y a un petit bouton à côté de le bouton de réaction, and it's an interpretation bouton. So vous avez le choix de anglais ou française. So hopefully you will find the interpretation, l'interprétation est disponible là-bas pour les francophones. Bienvenue. I'm going to share my screen with, just so I can go over these housekeeping items. Hopefully everyone can see that. So first, please turn on your camera if at all possible, if the bandwidth allows that. We're building a community of practice here and seeing everyone. Even though we're not able to be together in one place, we are trying to have a face-to-face gathering. Also, please keep your microphone muted during the session. Rename yourself with your name and organization by going up to the top right-hand corner of your Hollywood Square, and you'll see 3 little dots, and you should be able to rename yourself with your name and organization. If you're having any Zoom technical problems, please chat EcoIT, and they will try to help you troubleshoot those. We want to reserve the chat function on Zoom for questions and comments. So please refrain from noting attendance in the chat. We're tracking attendance using the PDA participant app. The QR code you see on your right is the start code for that app. There are instructions for downloading that that were in the announcement, and I'm going to go over those right after I do these initial housekeeping items. So you can find the download link and instructions in the announcement. At the end of the session, we'll also put up an end QR code, and we'll want you to scan out so we know that you came in and came out of the session. That will both give you an attestation that you participated, and it will give you access to Dr. Bird's PowerPoint. We'll also be sending the presentation slides soon after the end of the session or in the next day or so by email to everyone that registered. This session is being recorded, and your attendance is consent to be recorded. So thank you for that. There's also going to be or is a link to the COVID-19 One Health social media guide, and that will be in the chat. And it's a great guide for giving you tips on how to make the most of social media in promoting these One Health COVID-19 sessions. There will be continuing professional development credits available through the University of New Mexico. We'll put a link in the chat at the end of the session. And not only will you get CPD credits, but we will get your feedback to help us improve these learning sessions. So we really encourage you to do that, even if those CPD points aren't really important to you. And as I said, there is French interpretation available via the interpretation button at the bottom of the Zoom toolbar. So now I'm going to quickly run through an introduction to the participatory digital attestation app, which we're using to give all of you the opportunity of collecting attestations and a transcript of those for each of these sessions over the next few months, as well as instant access to the PowerPoint presentations. So this is something we'll be piloting through June while we're working on this One Health COVID-19 series. So as I said, if you can, please download the app by putting in PDA participant, either in the Play Store for an Android phone or the App Store for an Apple phone. Once you download that, you'll need to just put in your name and mobile phone number, and you'll get a confirmation text message to confirm that you've signed up. The layout of the app is very simple. There are only 3 buttons. The button on the left is for attestations. It'll be empty initially, but after today, you'll have at least 1 attestation there. The middle button is the QR code reader for scanning in and scanning out. And then on the right is your profile, which you can edit as you want. You can put a photograph in there and edit. There are a few fields you can add your email address, etc. And then there's a notification button up on the top right. The QR code reader is super simple. You just click that middle button and the QR code reader will be activated. If you're doing that now, once you scan the QR code that I showed initially, and I'll show it one more time, you'll get a check mark with a blue halo around it that signals that you have scanned in. Toward the end, we'll show the end QR code. When you scan that, you'll get a check mark with a green halo. And then after that, you'll have your attestation will appear immediately on your phone. And the image on the right shows that. This is one example with 5 or 6 attestations. And if the one on the top is the most recent one, if you swipe that card to the left, you'll get the full description of the training, as well as access to the PowerPoint presentations that were related to that training. So we hope you give that a try today. And I'll very quickly put up that QR code one more time so that you can quickly scan it if you didn't have a chance. We'll also put a link to the QR code in the chat if you didn't have a chance to do that right now. But with that, I'm going to pass the baton to Professor Jonna Mazet to formally welcome us.
Hello, my name is Jonna Mazet, and I am...
Jonna, we're not hearing you right now.
Uh-oh.
I can hear.
I can hear her as well.
Go ahead, try again.
Oh, you're hearing? Okay, go ahead.
Okay. Well, welcome on behalf of the One Health Workforce Next Generation Project and my colleagues at the AFROHUN Secretariat. We are incredibly pleased to have you join us for the 3rd in our series of COVID echo sessions, trying to connect us all for this mitigation and hopefully control of this sort of tragic pandemic that we're all living through. And today, we're very pleased to be working with you and hearing from you about what's working and what's not, and building this community of practice so that we can learn from each other. Yesterday, or depending on time zones, earlier today, we had a very good session with Southeast Asia, and we heard about most of the countries being having been sheltering in place for quite some time and being ready to move into the next social experiment of coming out of sheltering and being ready for what comes next after that. I know some of your countries are in different situations, different levels of social distancing and sheltering, and we'll be very interested to hear about that, what you're going through, how well it's working, and what we can do next. So with that, I'd like to hand it over to the co-host from the AFROHUN Secretariat to welcome you.
Thank you, Jonna, for this welcome message, and thank you the hosts, those who are hosting us. We are still in this close down of this whole thing. We believe that we are getting somewhere now. We are no longer we are no longer so frightened as we were at the beginning. I think we are getting used to the lockdown. But what is very exciting is that we are going to hear from different voices of different happening in countries, and we will hear from the different speakers as they will be introduced. But I'd also want to hear from them, although it may not have been said, what has been the role of our universities in this response. Since we are a university network, whoever is speaking from whichever country, I'd like all of us to know or to hear what has been the role of the universities, the students, the faculty, and so on. So it will help us to know whether we are making a reasonable contribution and what does it mean for our network. So once again, I welcome you to this, and I look forward to a fruitful discussion after you have made the presentation. Thank you very much.
Okay, so thank you so much, Dean Bazeyo and Professor Mazet, and of course, Dr. Struminger. I would like to introduce myself very briefly. My name is Valtrina Smith. I'm a professor at the University of California, Davis, and I'm really enjoying working very closely with AFROHUN and SIAHUN on the One Health Workforce Next Generation project. What we will do over the next 90 minutes or so is hear from a very distinguished set of panelists. We have 10 folks who have offered to share their ideas and experience. We will also be able to take questions through the chat box, and we'll be able to address some of those together, and also we'll follow up on the frequently asked questions webpage to provide more information later if we don't have time to do everything together today. So really thank you everyone for being here, for logging in from all over the world. What we'll do this time, we'll start out a little bit similar to previous sessions in that Dr. Brian Bird will briefly share a quick global update on some things that are happening. And then we'll go into our panelist sessions where we'll hear a little bit about what's happening in Latin America from our first panelist, Dr. Uhart. And then we'll circulate through our panelists from different African countries who have prepared some ideas and thoughts to share with us. So I'm really looking forward to working through this together, and I would invite Dr. Bird to go ahead and share his global updates next.
All right, thank you very much. It's great to be back with everyone on our third session. As the previous ones, I'm going to give a bit of an overview of the global situation for COVID disease and really try to spur the conversation on what's working and what's not. And certainly, at least in Tanzania, two people that I know very well, Mr. Walter Simon and Miss Happy Mekelle, are working very hard on the front lines of diagnosing cases of the disease in that country. So that's certainly a piece of this that's working, and that's really shows the strengths of us as a group, as a community of practice, and a group of scientists and public health workers committed to turning down the transmission of this global pandemic. When we look at the global situational update of the disease, we're now at about 2.6 million cases. Almost every country in the world is now reporting cases. It's certainly across Africa. You can see on the right there that I got yesterday from Africa CDC and Africa Union showing the intensity of transmission across the continent. When you look at other developments in the last 2 weeks since we last spoke, there are now over 60 potential vaccine candidates in development for SARS coronavirus 2, and at least 5 of those are already into human trials. But it still will be quite a long time before there's an approved, safe, and hopefully effective vaccine in the human population. There is increasing evidence, though, that there are some antiviral drugs that may be beneficial to treat severe diseases, or severe cases, sorry, but we're still waiting a bit more for more definitive data to really say for sure, are these drugs effective? Thus far, there's no strong evidence that any particular virus variant or virus lineage is more or less pathogenic in people. But of course, that's an area of research that will continue to be monitored and looked at as we go forward. Also wanted to point out a website that is very good if you want to look at all kinds of data regarding diseases or other metrics about our world. And the website, if you look at the link in the lower right-hand corner, here is Our World in Data. And I use that to pull together this slide, which shows the confirmed COVID-19 cases.
Hey, Brian, I think we lost your sound.
So it looks like he's still connected.
Can you guys hear him?
Chatting. I cannot hear him.
Dr. Bird, we lost your sound. Can you maybe try to mute and unmute again or something?
How about now?
Yeah, now it works.
Oh.
We lost you after you were talking about the gathering data from different countries from the website.
Oh, okay. So when you look here on the chart on the right, what this shows really is both data from the United States, the world, and other countries in the AFROHUN network. And what I think is what to look at is, yes, cases are increasing in each country, but definitely there are different trajectories in each of the countries. If you look at South Korea compared to the United States, and now where our countries across the African continent are. And why are these differences? And that's the point of today, is to figure out what's working, what's maybe not, and how can we improve our control efforts. So is it the social distancing? Is it community strength and resilience? Is it the wearing of face masks, or differences in government testing and isolation of cases? Community engagement, community surveillance, as we talked about last time, or is it other things that we haven't even considered yet? So I'm very much looking forward to that discussion and learning from you what's working and what's not working in your country. And as usual, my last slide, because you'll have these slides available, has links to all the information that I've talked about before. So please check out these websites, get factual information, and then share that with your colleagues around the world. Thank you. Back to you, Dr. Smith.
Thank you so much. Okay, so what we're going to do now is to hear from colleagues from several different countries. Then we'll take a little break for some Q&A from the audience as well. So Dr. Uhart has joined us from Argentina, and she offered to share a little bit about what's happening in Latin America, just to help put some context in, because I know sometimes we can learn a lot from other parts of the world. And Dr. Uhart, would you like to just very briefly share your thoughts on what you've been experiencing and hearing about down there?
Sure, thank you. Hello, everyone. It's a great pleasure to be with you today here. Yes, I think it is interesting to compare what's happening in Latin America with the situation in Africa. It is relevant because we basically began getting cases at the same time as Africa. Most of those imported from Europe, mainly Spain and Italy, and also the US. So the onset has been late February, but mostly the first week and second week in March. So I think that places us at the same kind of timeline in terms of experiencing COVID-19 positive cases in our countries. And there are three things I think I want to mention specifically, and those are the differences across countries in the region in terms of three measures. One is the disclosure of information. We have a lot of differences between countries due to political differences, mostly, not intentional from healthcare. But the issue is that we oftentimes don't have good information coming from some countries, and particularly what's lacking, and it makes it very hard to assess success of measures and how good we are being at flattening the curve, is the lack of information or reporting of tested cases. So the reports of positives is done, the reports of deaths and recovered is mostly done, but we don't have numbers of how many people are being tested. And that makes context very difficult to understand where we are and the efforts that different countries are placing. And this also links into my next comment, which is referring to quarantine and how we deal with self-isolation methods to flatten the curve. And without testing massively, it is going to be very hard to understand whether how much things change and how should they change and where in terms of making those restrictions more flexible. So right now we have quite a bit of disparity around countries in terms of how severe the lockdown is. So in some cases, like Argentina, where I am now, it is complete lockdown, not even allowed out for a walk. And that's been over a month now. And it's a case for several other countries. And then there are others, like Brazil, where there's huge conflict, where the national government says no restrictions, and then some of the states that are being hit very heavily by the pandemic are actually imposing quarantines and lockdowns. So also, if you look at the data of when the cases begin to raise and the countries that are having bigger issues, you can see that a lot of that, there is an association, a connection with the time of implementation of these restrictions and how fast the number of cases are increasing. So that's another thing to consider. And then I wanted to finalize with a comment on quarantine and lockdown, and just suggest that if you are interested, you should look up some of the measures that Chile is taking, for example, where they're taking a very good, what I think are a very nice set of indicators, ranging from cases showing up in new locations where they were non-reported, the demographics of the population in certain areas, the number of cases per location or size of the area or population in that area, et cetera. So they have come up with a set of indicators that are allowing them to make their quarantine measures flexible. And what they're doing is just rotating amongst neighborhoods and areas in the country and making the lockdown flexible and seeing how that works. And they're ready to put more strict measures in place the minute cases start increasing. But hopefully their exercise or their trial of this method, which is the only country in the region doing it, will help us, other countries, assess whether that is a way to get out of the strict curfew on lockdown that several countries in the region are in right now, which is causing humongous social and economical losses. And these countries are poor and will not be able to sustain this forever. So those are, I think, my 3 main points. Thank you very much.
Yeah, thanks, Marcy. I think, it's really helpful to hear ideas and really to get the discussion started. So thank you for providing that context. Of course, we could provide context from the United States as well, where we've not done a very good job in being able to really stay ahead of things. But I think right now we should be able to hear from some of our colleagues in different African countries from AFROHUN and be able to move forward from there. So I realize that some people are having some network connectivity challenges. That is always the case. We are recording the session and we will post it. So if you are having trouble with internet access, please don't worry too much. Feel free to join with the link that we'll post later and will be shared by email in case there are some bits that you don't get to miss. There also is an opportunity if you want to share a little bit more about either your experience or ask a specific question, please use the chat box for that, because we may not get to all of those things in the live discussion session. But this is a way to build our community of practice with the chat box thread as well as our panelist discussion. Okay, so why don't we go ahead and see how we're doing on connectivity from our panelists here. I think we could go to Dr. Monica Musenero from Uganda, and then after that to Dr. Mabel Nangami from Kenya, if their connections are okay. So Dr. Musenero, are you with us and able to share your initial thoughts briefly on what's working and what's not from the Uganda context? I'm just scanning through our participant list here to see whether I can tell for sure whether your connection is here. So Dr. Monica Musenero, if you are able to be with us, now would be a good time to share your thoughts and to unmute your microphone. If not, we can certainly come back later on.
Hello.
Hello.
Tina.
Yes.
Monica is trying to connect, so maybe we'll go to the next one.
Sure, no problem. Mabel, how is your connection? I think Dr. Nangami is calling in via her phone, but I have some slides that I can share on her behalf if her connection is well enough to talk with us.
Hi, it's Matt from IT. Just a reminder, if you're on the phone, you'll need to enter *6 to unmute.
Okay, thanks for that tip. I wouldn't have known that. Okay, so if Mabel is going to be perhaps checking that, we can go on down and we will come back and circle on. Okay, so from Rwanda, we have Dr. James Humuza, who is going to be joining us from the School of Public Health at University of Rwanda. Dr. Humuza, how's your connection? If you're able to unmute and share your thoughts, you're very welcome. Dr. James Humuza from Rwanda. Okay, so I'm going to keep going down the list and then we'll have to sort out how our connections can work. Otherwise, you'll hear much more about what we think in a loose way. I know that from Ethiopia, we had Dr. Abrha Bsrat with us, and I know there were some connection challenges. Dr. Bsrat is from Mekelle University. How is your connection?
So I'm following.
Yeah.
Is it working for?
Yeah, why don't you go ahead and share your thoughts next if you have your connection working right now. Thanks for being with us.
Thank you for the invitation and let me participate in this connection.
Yes.
Actually, I'm very happy to participate with this because we had a very challenging time for last 20 days in the country actually because of many things. So I can have some points on the first one on social distancing.
Yeah, that would be fine.
Because of many is it okay?
Yeah, now that your video is off, I think it's easier to connect. So I say, yes, please share your thoughts on social distancing and what's happening in Ethiopia. And go ahead and leave the video off if that helps with the connection. That's no problem. Thank you.
Okay, because of many barriers, of course, the government has launched and tried to create an awareness between the communities through different medias, including the social media and all television radios in the country. But with very different culture in the country, especially and the behavior of gathering in different events like wedding, church, is yet very difficult to achieve the expected issues from that. For instance, I'm in the northern part of the country, in Tigray, and the regional government in our province, I can say, already has locked the region, any person coming to the region from different part of the country. And if they come, they already again set a quarantine station, and then they are letting them to wait in these quarantine stations. And fortunate enough, now I'm in my campus, and in the dormitories in the campus where I am now, we are having about 310 individuals already quarantined or isolated. They already came last week from different parts of the country, including Addis. But with this Yet the regional government and the national government is facing two different challenges actually to make effective social distancing and the isolation and quarantine. With that, there are some barriers, like as I said, the social barrier is first, and economic barrier is also another challenge for the country, like access to water in the quarantine stations, and income also, even for those, because the government said that those who are coming from outside the country and also from region to region, they should cover their expense while they are in the quarantine. And that is also another challenge because of some budget or financial problem from the government side. And also there are some limitations access to PPE, like I was hearing that the face mask and different issues, but in Ethiopia is so risky for us because even there isn't a single company who can produce the face mask. So that's also another challenge for the country, and also some infrastructures and facilities, especially in the health system of the country. Diagnostic centers are very limited. Even I can say that within the country, we had a maximum of 300 oxygen ventilators. Most of them, they are old. For instance, in the region where I am now, we do have more than 8 million people, but 10, most of them which are old ventilators are available. And again, isolation and quarantine centers are the challenges of the government. For instance, as I said, in the country, the whole country, we are using the public universities as quarantine and isolation centers, and even treatment centers. Of course, the data we are having currently is the number of cases in the country with about 110 million people. We are having currently 116 cases, but I'm not sure that this is the only case, because as I said, because of the lack of diagnostic centers in the country. Of course, especially the public universities, they are trying their best to establish diagnostic centers for all, but still they are not getting kits for the missions. And also even it's very difficult for us to get the real-time PCR for the pathogen isolation. However, the government is trying its best, at least to by setting some questionnaires to look if there is any maybe risky situation in between the regions, in between the peoples, in between even the local districts, but still it's challengeful actually. So I can say that as a country we are so being so challenged. That's why I'm here. And even last week I was communicating through email for all AFROHUN members to if we can have an opportunity to get some supports for at least for the diagnostic system and support for the countries and nearby. For instance, I'm on the border to Eritrea, and there are many countries in Eritrea, many kids in Eritrea, and we are in fear because there are illegal movement in between, which is very difficult to lock down that due to the situation in the country. And another very challenging, especially in the university where I am now, is there are thousands of people quarantined in the university campaign. But after 14 days, they will be released. But there is again psychological challenge in the community nearby, because there will be stigmatization for them, and even still there is a panic from the local communities to have a relationship with those individuals. We don't know whether they are positive or negative, but we will release them after 14 days if they do not have any clinical sign. So that panic environment in the community is also very challenging. And another thing is, again, there is fearing to white peoples in the area, because they
Dr. Bsrat, I think we lost your sound. Are you still with us? Just a few seconds ago. Abrha, are you able to hear us? We're not able to hear you right now.
So it looks like he might have lost connection. He's still on.
Yeah, it's often intermittent with our colleagues in, well, in many places, but especially in Ethiopia.
We are getting, I know that we're trying to build our community of practice, but, and it is very nice to all see each other, but we are getting some messages in the chat, and we've had some IT discussions that if we do all turn off our videos except who's speaking, it makes the connection for the people trying to participate and receive the information much better. So we may want to consider turning off all of our videos except when you're speaking, unfortunately, or maybe Professor Smith leave hers on and the others. It's just a thought that it might help the people that are having connection issues.
Yeah, we can give that a try. My impression had been that for Zoom in particular, your connection is driven by your individual bandwidth, not by the collective use of bandwidth, but certainly it wouldn't hurt to give it a try, to turn off our videos and see if that helps for today.
I think it is the individual bandwidth, but it's what they're receiving. So if they receive too many videos, it shuts them down.
Yeah. So, so with that recommendation to see if it's helping for today, go ahead and turn off videos, and we'll keep the discussion going and be able to see whether that's helpful for folks. Good idea. So, okay, let's go ahead and for Dr. Bsrat, in case you are able to finish your comments, you're welcome now. Otherwise, I think we have really enjoyed hearing those initial thoughts, and we certainly can come back to you a little bit later. Okay, so I think we will pause there and go ahead and go on to our next panelist. And it looks like that we had Dr. Mabel from Kenya, who needed to be pulled out for a separate thing. I'm not sure if she's back yet, but she did say that Sam Wanjohi from the Kenya country manager for AFROHUN would also be interested to share the thoughts they had been discussing. So Sam, are you able to unmute your microphone and either share slides, or I can pull up the slides that she gave if you'd like to be able to talk through a bit? So that would be for if Dr. Mabel Nangami is with us, or Dr. Sam Wanjohi would like to share the Kenya ideas. Otherwise, we'll keep going down to see how our other colleagues are doing with their connections. Okay, so I'm going to keep going then. Let's see, for Senegal, we were hoping to have Dr. Adama Faye. Oh, I think I heard. Go ahead.
Hi, sorry, I was trying to unmute myself, so it was giving me a bit of difficulty. So
Hi,
I don't know if you can hear me. Hi,
yes.
Hi, Professor Smith.
We're good. Would you like
All
me
right.
to screen share the slides that you and Mabel put together, and you can share some thoughts along with that, or would you like to do it differently?
Yeah, sure. You can kindly share the slides that she sent to you.
Okay, let me pull those up for you here. Okay, so I think folks can see the screen, and I'll go ahead and put it in present mode. And then Sam, talk us through a little bit about your thoughts on what's working and what's not for Kenya right now.
Right, great. Thanks, Professor Smith. So I'm definitely not Professor Mabel. So my name is Sam from the Kenya Country Office for the OSHARE program, soon transitioning to the Africa One Health University Network. So we'll be looking at some of the things that are working or not working for the strategies, the COVID-19 strategies in Kenya. And I think this is the presentation that Professor Mabel and I were working on. So next slide. All right, so before the occurrence of the first case that was reported in Kenya, I think the country had made some steps in preparing for the same. Just upon the realization of the event that was happening in China and in other places of the world. So the country, Kenya country, came up quickly and developed some contingency plans called the National 2019 Novel Coronavirus Contingency Readiness and Early Response Plan, amongst other documents. So that was done before the first case was detected in the country. So the first case, I think, was detected in the country around March. And once that happens, the response and coordination was activated. This is where we had the National Emergency and Response Committee that had been set up in the pre-occurrence stage, if I can call it that. This committee was activated. So it has several other subcommittees that are assisting in the implementation of the same. So that happened. The activation of this committee was done by the president. And this committee is spearheaded by the Ministry of Health. So the cabinet secretary for the Ministry of Health is the one in charge of this committee. So the other strategies and measures that were implemented thereafter were the physical and social distancing that were done, and messages to that effect were sent out, as that can be seen in that image on the right. Next slide. So we also had case management, and we still have case management and IPC measures that are being implemented, and including the emphasis on hand hygiene, cough etiquette, self-enforced quarantine, the establishment of quarantine and isolation facilities, which was done in various institutions, government institutions, including middle-level and tertiary colleges that were identified and set up as quarantine facilities, and various hospitals and healthcare institutions that were set up as isolation facilities. We also had the development of various guiding documents, including legal notices, various legal notices, directives and circulars on the administration of justice, especially in the judiciary area. We have the ministries, government ministries, departments and agencies having guidelines, policies and directives on how they should react or respond to the COVID-19 outbreak. The government also set up, or rather implemented curfew. This is from 7 p.m. to 5 a.m. nationwide. We also had partial lockdown or containment of various areas that were declared COVID-19 infected, including Nairobi, Mombasa, Kilifi, and Kwale. We also had the closure of airspace. Then we had financial and economic interventions that were also set up, where the government came up to give tax reliefs to various working formally employed persons. We had the banking industry reviewing some rates. We had tax rates being reviewed. So we had various financial and economic interventions that were set up just to mitigate the impacts of the COVID-19 on various people within the population. Then we also had risk communication being set up quite well as a strategy that the government employed. Next slide, please. So for us, I think what we can see working is that the use of the complementary approach and coordination is working, where the National Emergency Response Committee coordinating through various sectors and working across sectors, because this committee is comprised of the Ministry of Health, Ministry of Internal Security, Education, amongst others. We have the Daily Incident Management Team that continues to prepare reports and give and advise the Minister. We have the Emergency Operations Center. We have the Kenya Humanitarian Partners that are also working together to address this pandemic, including the IRC, Kenya Red Cross, ACF, MSF, amongst others, and key UN agencies. Case management and infection prevention and control has also been enhanced and is continuing. I mean, implementation is going on, where we have case management in isolation units. These are in the healthcare facilities that have been set up in the country. Testing and screening and lab diagnosis being done to the best of our abilities as a country. Surveillance and contact tracing being enhanced within the country, within the resources that the country has. Training and capacity building of various cadres of health workers. We have the training and capacity building of various other workers within other sectors like the security agencies within the country. We have risk communication that is being done, where the cabinet secretary or his appointee gives daily briefs to the country. And at times we've seen even the president giving briefs to the country. We also have a frequently asked questions forum, and people can call in on a toll-free number and ask their questions and that get answers. So that also seems to be working well. Next slide, please. So in risk communication, some of the methods that are being used currently are the bulk messaging through text messages. And here the Ministry of Health has worked very well with the telcos, for example, Safaricom, which is one of the big telco companies in Kenya, to support the sending of bulk messages to the public. We also have digital media and mainstream media passing messages on what to do and what not to do in the country. So we also have implementation of measures in most limited geographic unit. For example, like I mentioned, the containment of Nairobi, Mombasa, Kilifi, and Kwale in a manner to indicate that you cannot move out or move into these countries, or rather into these counties, so as to see if we can be able to limit the spread of the disease to other areas that are not yet as quite affected as these counties. Then we have community engagement. Various community groups have been engaged in the preventive measures of COVID-19. We have innovations that have come up. We've seen innovations in Moi University through the Rivertex, Kitui County textile companies, where masks and other PPEs are being now produced in these companies. We have a prototype ventilator that was developed by KU students, Kenyatta University students, that is to be tested and probably, if it works well, then rolled out. Then we also have partnerships where we're having support and buy-in from various stakeholders and other well-wishers just coming in to support the efforts that the government is putting in. So those are areas that are working quite well. Next slide, please. So like I had indicated, these are sample figures of what has been done. 1,000 police officers have been trained, particularly those manning roadblocks. We have 1,000 National Youth Service officers who have also been trained, 300 prison officers. Now you can see these are not in the health sector. So just laying an emphasis on the sort of One Health approach that the government is taking to address the COVID-19 outbreak. We have 53,000 community health volunteers that have been trained. And the government has also done considerations for vulnerable populations. For example, like in the picture that you can see there, there is a payment of some 8.75 billion Kenya shillings in a cash transfer method to sort of cushion the people who would lose income or get reduced incomes, so that then they can be able to see how they can be able to eke out their living, so to speak. The other things that are working are the closure of markets and social gatherings. This has worked out, and the government continues to emphasize on the same. Next slide, please. We nonetheless have challenges. For example, the individual responsibility, people taking up individual responsibility. On the right there, you can see the clip of some people. I think, and when we looked at this clip, it was the quote was that these were people fleeing Nairobi when the lockdown was announced. Instead of staying within the geographic limits of Nairobi, they decided to flee from Nairobi instead of taking up the responsibility. And yet the lockdown was to contain the spread of the disease within Nairobi and not take it outside Nairobi. So without this knowledge and without people taking their individual responsibility, we are seeing that is a challenge that we're having. Very many clips circulated in WhatsApp and other social media forums indicating, showing people trying to find routes of escape out of or into Nairobi and being innovative into that. So individual responsibility is a challenge that we're currently facing, indicating behavior change is complex and slow. We also have challenge in environmental management with the disposal of the masks, face masks, like can be seen in that photo there. Fortunately, the Environmental Management Authority, I think, and the Ministry of Health came up with some guidelines to guide how this can be done from the homesteads. We have anticipated unanticipated effects like reduced incomes, the special and vulnerable groups, domestic violence, that some cases that are being reported of increased domestic violence coming up with the implementation of the measures. The management of quarantine centers was also seen as an issue where people are escaping. Actually, there is even a clip that was circulating sometimes this week indicating that showing some guys jumping over a fence from one of the quarantine centers. There have been also cases of bribery and payments of people to get out of the quarantine centers. So that is a bit of an issue. And there's also some directives are also difficult to enforce, like the rent reductions or rent waivers, water reductions, power and electricity issues. So those are still challenges that we are facing in the implementation of the measures. Next slide. So when it comes to the health system's preparedness and implications for response and outcomes, we have seen reports of the slow adoption of the web-based COVID-19 surveillance and data management system. So the health system is yet to take up that. In terms of case management and infection prevention and control, there are inadequate numbers of trained and skilled health workers. We have inadequate PPEs, inadequate supply of lab testing kits. And then the contact tracing in the quarantine centers is a bit of an issue, which would have an impact on the outcomes. Next slide, please. So as we continue, governance and leadership has been noted to have an issue on the outcome, where we're having MOH leadership being key, and the National Steering Committee, the financing of the government. At least the government had looked into the financing, and they're looking into supporting the counties with finances to help them in their response, preparedness and response activities for the COVID-19. The issues of human resource, we have had the element of hiring of additional health workers. And coincidentally, and to answer Professor Bazeyo's question earlier, this has been extended to the universities. So the universities have been requested to second staff to the COVID-19 outbreak response activities. And I think that is one of the things that Professor Mabel has gone to attend to in this regard, university assistance to the COVID-19 response. We have issues of medicines and technologies, availability of bed space, ventilators. So a lot of innovation is going into there. One of the counties, I think it was Machakos County, designated one of the stadiums as a health facility now for that regard, in preparation of the COVID upsurge in the cases. So medicines and technologies, the bed space, ventilators, life support equipment, testing facilities. We have partnerships with private labs to enhance their capacity, and even private hospitals coming in to boost up the preparedness of the health system. When it comes to service delivery, we're having this implemented at both at the health facility level, community level, and individual level. And we are having the MOH giving regular updates, as we have indicated earlier. Next slide, please. So we are seeing that the measures being implemented as at the time of the start of the mandatory quarantine and the testing of persons. And this is just a graph and a schematic to show how the cases have been observed. And this is as at 21st. And I think the next slide would show up to today, where we have, I think, 303 cases as at today. Yesterday, 22nd April 2020, indicating the number of new cases that we've received, the number of deaths, the number of total confirmed cases, and what we are experiencing with the implementation of the measures. Next slide, please. So the lessons we've learned is that it's key. Political leadership for clarity and effective communication is key, where we've had the Emergency Response Fund being created. We have the prompt actions by Parliament and legislators to give the documents that are indicated, the social safety nets, logistics in various counties. We have planning, policies, and guidelines for effective coordination across sectors that have been given out, as I've indicated. We also have the opportunity for the country to fund a robust health system. This has given us an opportunity to look at. We are learning that behavior change is complex. It's not as clear as day and night. Next slide, please. So we're also learning that there is a need to balance health and economic needs, looking at the various social measures that are being implemented vis-a-vis the various socioeconomic levels in the country. It's important we are learning to give information to avoid panic. This is being done. It's important we are learning how and when to deploy security forces and how this can be done, observing human rights, dignity and human rights. And we're also learning that, okay, this COVID-19 issue is a wicked problem, is a complex problem that has unintended consequences, like the increase in domestic violence, which it can enhance vulnerability, that this disease cuts across various socioeconomic groups, and it will give us a new normal. Next slide, please. So all the information is being guided by the MOH. It's being channeled through the Ministry of Health as the lead agency in that. We're having the regular updates shared by the Cabinet Secretary, and myths and misconceptions, rumors and frequently asked questions are being addressed through the toll-free number that is manned by the Emergency Operations Center. So the needs for information are well managed, so that the privacy that needs to be observed is well observed. So that is the management that has gone into, or the structure that has gone into the issue of the information. Next slide, please. All right, take-home message. Stay at home, maintain social distance, seek medical assistance upon suspicion of signs and symptoms. And I think that is one of the images. Unfortunately, we haven't given the credits. I believe before these slides are shared, we'll be able to give the photo credits for all the images that have been used. But this is one of the messages that we need to say. Stay at home, maintain social distance, observe personal hygiene, and seek medical assistance upon suspicions of signs and symptoms of COVID-19. Finally, I think the last slide is on acknowledgements. We wish to acknowledge the USAID program, the UC Davis-led consortium. I think all members are there. We also want to acknowledge ASHARE. We want to acknowledge the Ministry of Health and the Kenya government. Thank you so much.
Thank you, Sam. That was an excellent way to walk us through some of the things that are working and some of the challenges that are really facing this point of finding a new normal. That's something we heard a lot about in our Southeast Asia discussions yesterday, is that, you know, they're a little bit further along than all of us in trying to work their way out of the COVID-19 pandemic. And as they think about reopening some of the economic aspects of restaurants and barbershops and regular, you know, day-to-day activities, trying to do that, they talk a lot about having a new normal because we may not be able to do things in the same way we had done them before, given the transmission dynamics and the awareness that we're trying to build. So it is a very interesting and challenging time in many places, and I'm glad that we can learn from each other. Okay, so Irene, if you would like to share very briefly your comment on the role of universities, we can do that, and then I think we'll go on down to hear from Dr. Kakoko in Tanzania. But Irene, did you want to unmute for a moment and share your thought?
Yes, thank you so much, Watrina. I just wanted to highlight the roles of universities that we are seeing come through the AFROHUN member universities. I'll highlight, for example, in Uganda, we are seeing that a lot of scientists are being consulted, and we are seeing a lot of science being used to speak to interventions. So a number of the people on the scientific committee that government put forward from the universities. So we saw that, I know that Professor Abrha, when he comes back, he can speak to that, but him and the country manager are always on radio, sensitizing and responding to questions from communities. So we are seeing universities coming up to provide answers based on science. And in Uganda, I think this is a general problem everywhere. It's a new disease. There are so many questions. The communities have questions. So we are seeing that explaining, giving answers using science, people are going to start understanding why they shouldn't be escaping from quarantine. If they're hearing from a professional and explaining the reason behind in a simple way, then people are going to appreciate why they should stay at home. So that has been frequent in Uganda, and from that we are seeing the narrative of the communities changing from why should we stay at home to now we understand, let's just cooperate with government. So the narrative is changing to cooperate with the guidelines as explanation is coming, and we are seeing a number of professors being interviewed and speaking to this and using science to explain why they need to stay at home, why we need to wash our hands, because people are not understanding why are you telling us to do these things. So I'm saying that, and also in risk communication, we have a number of concepts that are coming from our network institutions to try and beef up government guidelines, innovations, capacity building using forums like this. So I just wanted to bring that to in the event that we don't get some of our faculty to speak. I submit.
Thank you so much, Dr. Nagaga. I think that's a very helpful overview of the roles that universities are finding to be able to contribute in a very important way to some of these ongoing issues. So I would invite panelists, if you would like to, you're very welcome to respond to comments and questions that are coming in through the chat box. You can respond back to that if you would like to. We will also get to questions to the extent possible within our 90 minutes. So we're going to go down to Tanzania next. And if Dr. Kakoko would like to share thoughts on how things are going there, you're very welcome.
I'm from Mumbai University of Health and Allied Sciences, a part of AFROHUN. And I've just a few things to say on our side of Tanzania. And I think most of you know very well that Tanzania has been very unique in the context of COVID-19. And that's because our approach has been somehow quite different, where most of the countries opted for lockdown and other approaches. The unique thing in Tanzania, we have not opted for lockdown. And the president has always been saying about that it's due to economic reasons that the country is not ready. And yesterday he spoke to the country. It was very clear that you are not going to the lockdown. And the unique feature of this country, quite different from other countries. I'm not going to repeat what most of them said because some of the strategies are similar. I'm just looking at these differences. The use of faith-based approach. Since the beginning of the pandemic, of course, the approach has always been like, if we pray, things are going to be well. And you remember, it's now the speech of our president was very popular, that COVID-19 is the work of the devil. And therefore, you cannot shy away from praying because that's the only way to get away from COVID-19. Now, that has had a lot of sentiments and implications in the country because the way that we are adopting preventive measures have been quite different. So, but importantly, the key question is what went well and what did not go well. Despite such approaches, in Tanzania, of course, we have been responding to COVID-19. And the first response was closure of the schools and colleges. At the beginning, immediately, when we got the first case, immediately the government, the prime minister announced to close schools and colleges, knowing that in context of the schools and colleges, transmission could be very high, especially when you look for young school children. We couldn't control them, and contamination could be, transmission could be so high. So that was done effectively. And when that was announced, almost all the institutions responded immediately, and there was really the first response to that, despite challenges which were here and there. The second success has been on the preventive strategies. Despite using the faith-based approach, there have been preventive strategies, and the three main ones. One is the use of hand washing, using flowing water with the soap. That has been done, and it has been a directive, and most of people have adopted it. When you go around, you see at every shop, at every place, in the families, almost that has been done almost by everybody. Now people wash hands, and people are saying, like previously, we heard during cholera epidemics, people couldn't wash their hands. But for the first time, we have realized that the response has become very, very high, and with the immediate effect. So washing hands has been very effective. But the other one has been use of sanitizers, and people really are using sanitizers very, very effectively. And despite the cost, some of the people, of course, cannot afford the cost, but people are using hand sanitizers, and that has been done. And one law of the universities, for example, at Muhimbili University, as well as the Dodoma University and other universities, with their pharmacy and medical sciences, has been making those sanitizers and selling them at the reasonable cost. So that has been very successful, and sanitizers are produced by the universities. The third success in terms of prevention, the use of face masks, and really people have adopted that also very fastly. For some of the regions, it has been a directive of the authority that it's a must. Wherever you go, if you get away from your home, use the face masks. Yeah, so that has been well adopted by, I can say, by many, because there are still some challenges, because not everybody can afford, for example, N95 mask or the surgical mask. Most of the people I can see, we can see around the streets, are using cloth-made masks. And that's the reality, especially when you look at the people who have less income. And the third success has been people responding to the quarantine, and that has been domestically and internationally, like the president announced that all international travelers, and before especially they canceled international flights, all international travelers were supposed, when they arrive to the country, are supposed to be tested. So they get tested, but whether they are positive or negative, they're also put under quarantine. So that's common in the country. So there have been really several success, and to mention a few, because some of them are similar to the other countries. But despite this success, what went well, there have also been some challenges or things that might not be going on well. Yeah, as I said, one of them has been the use of faith-based approach that has a broad different sentiments. People have different understandings. There is a kind of disharmonious situation where some people are supporting that, and some people are opposing that. Really, they are not comfortable with that. So that has been a big challenge. People looking like we need to adopt medical approaches rather than faith-based approach. The second one is the issue of physical distancing. Is still a problem in this country, since we did not opt the lockdown. And I realize, like in most places, like in the commuter buses, though they say it should be, all people should sit and they should have masks, but when you look at the reality, at the bus stops and elsewhere, you don't see people observing the physical distancing. And remember that even the business is going on as usual. People are going to the workplaces. We have not closed the churches. We have not closed the clubs, this and that. So there are a lot of things going on in the country that may be attributable to the increased number. Remember, we're almost ready to report the first cases, but now we have almost 284 cases. And that seems to really make a part of the problem attributable to the problem of physical distancing. Yeah, there are also challenges facing the healthcare system in terms of human resources for health, equipment, and the other aspects, and which bring about inadequate care to the patients. I understand that the country directs that people who suspected themselves, who think that they have the symptoms, the directives are also at the pharmacies. If they suspect somebody the COVID-19 symptoms, should be directed to the health facilities. Like in Dar es Salaam, we have a list of facilities, we have a telephone call number where people can call. So people have responded positively, but the challenge has been the response of the healthcare system. I may cite very, very updated information. Today, in Dar es Salaam, one of the big hospitals in Ilala district in Dar es Salaam city, where most of the COVID-19 patients are under care. Today, they blocked the doors, they stoned everybody, they ran away. So it's like now they are scattered today, they're going to be scattered around the city. And they say it's because of the care. So let's see break news that we got today, that things are not so good because those people said that they don't get care, so they are going around the streets. And of course, as said from Ethiopia, the issue of increase in stigma, there is increase of stigmatizing attitudes and discriminatory practices of the people suspected to be COVID positive. Of course, there's a normal response of fear with the condition, the disease that has a high toll. Of course, people have the tendency to there is always a tendency of stigma, but the worst scenario is when the healthcare system cannot respond well to the care of these people. You find like medical doctors, since they don't have adequate equipment, then they shy away from patients. And we are told that sometimes they don't even pick the phones because they know that they can get also infected. And we have some whispers, like some of the medical doctors. I know one who has been said informally that he passed away. He was a very famous pediatrician, but it said it was because he got infected and he was ready to be noticed. So that creates the issue of stigma that need to also be paid attention. Yeah, but the fifth challenge or something not going on well is the issue of information and data. Really, we have a big problem with information and data in this country. And it's we are told that it's only the minister who is going to be releasing the information, as well as perhaps the prime minister, the vice president, the president, 4 persons. But we realize that there is a big challenge of informal information in terms of data. People are not happy of what they are being told. They suspect that there are more people than what is being said. Some people say it's less. And even the president, in his speech yesterday, he added that saying that he doesn't trust the existing data. So it's sometimes strange, even when the president said that he doesn't trust existing data. So which means we might be on the higher side or on the lower side, but people are really not trusting available data. Importantly, also the 6th one is the ceremonious communication. I think that's the most challenging thing, whereby we have a lot of sources of information, despite the fact that initially they said it's the minister who would be releasing the information. But what the minister did was to release data in terms of the number of cases, people who died, the people under care. But there have been different sources of information in terms of prevention, in terms of symptoms, in terms of care of patients. And that has created a lot of problems. What should people do? And the health professionals have always been providing information, but at the end of the day, you realize, especially in the context of communication through the social media, has overwhelmed them, and you find level are coming up with the information, what should people do, what should people don't do, even when they are not competent to provide such information. Now, I remember even the president yesterday was saying, like, he gave a lot of the criticism on how people are communicating. Like the deputy minister yesterday had said, people should not use this steaming, using herbs with the steaming. So that because people, this cannot be trusted. People are using steaming to treat COVID-19. And when he said during the day, in the afternoon, the president said that's the best approach. People should be steaming. So you see the deputy minister, the information from the deputy minister contradicted with the information that the president gave. And today people have started adopting, because they trust the president, they have started adopting what the president. So really, that's a very, very big problem, especially the issue of disharmonious kind of communication in relation to COVID-19. From the university perspective, of course, we have started developing the proposals, and as I said, the schools of pharmacy and medicine have been participating, but very little have been done, especially in Tanzanian context. We are starting vigorously to think of the different research. Like in our research context, we are thinking of rapid assessment, like looking at the aspects of knowledge, attitudes, and the practices of the people in the context of COVID, and how things are changing in the context of COVID-19. But people, some of the university professionals who have the committees, and some of the professionals have been participating. I can attest, like Professor Kireo, who is the manager of AFROHUN on the side of Tanzania, was appointed by the minister to lead a team that was discussing issues of face masks. So he led that team, and from his epidemiological point of view, he made some suggestions that were adopted at the country. So as the academicians, we are still finding some more room to push and see how can we do the best, especially when it comes to the issues of prevention. So in the nutshell, those are some of the aspects that prevails in Tanzania, and I hope Professor Kireo will add up something later. Thank you.
Thank you so much, Dr. Kakoko. The comments and experiences and being very open is really appreciated, because hopefully by sharing these, we can find solutions together and to understand how we can work across different contexts to be successful. So I do want to loop back now to invite Dr. Monica Musenero from Uganda as the Presidential Advisor on Epidemics to share just a few brief thoughts, if she would like, following on what we've heard so far. Is your connection working, Monica, and are you able to unmute?
Not okay.
Yeah, we can hear you.
Thank you, everybody.
Welcome.
Okay, thank you. I'm called Dr. Monica Musenero Masanza. I work closely with Oshea Knights Uhart. I have to get used to the new name. I usually work as a consultant, technical consultant. Right now, I work as a senior presidential advisor on epidemics. I'm a scientist with a long working relationship with Mekelle, but also with the Ministry of Health. Now, I will not go through many things are similar to what Kenya has done. Uganda has a long experience with managing epidemics. Almost every time we are dealing with an epidemic. So through that experience, we have built some things and adopted some cost-effective measures which help us to quickly understand what we should do and put in place measures. So as soon as the country heard about this outbreak in China, they had some understanding that was spreading from person to person. At that time, we were still trying to work on the Congo, the DRC Ebola. So we had some things already up and running, the cross-border monitoring, the intensified surveillance through the country. So as soon as the information was gathered and we got to know that the disease can spread from person to person and other countries got infected, the screening was activated. Hello?
Go ahead.
Screening was activated at the airport. Screening was going on at the airport for long, and then we started preparing the country. The National Task Force was activated, and the Minister of Health put up a structure to do preparedness. For a long time, we were set up a surveillance system and were screening a lot of people using the non-laboratory methods. But as soon as we were able to get the diagnostics, we started to do surveillance through the country. Up until March, we identified countries that were categorized as category 1, those which were having lots of cases, and we started recommending, or it started like screening those people, but also recommending self-quarantine at home. That went on for some time, but we realized it didn't work. People couldn't self-quarantine. They would just be moving around, and we realized that if the danger became too much, that one will not work. So eventually in mid-March, we decided to have institutional quarantine. That was before we got any cases. We had institutional quarantine for people coming from category 1. Those were the countries that were having high numbers of cases. So we put institutional quarantining. By then, of course, travel was low, so hotel occupancy was very low. So we identified particular hotels where people were quarantined, and they were informed when they were still outside that if you come in, you'll be quarantined and at your cost. We went through, it was not easy to enforce that because still some people were not complying. Some were refusing to pay for the quarantine. And because COVID is new, information is rapidly changing. However, we debated a lot with closing the airport. We learned a little late that some of the countries that we had left, because they were not, some countries seemed not to be reporting accurately about their incidence rates, about how many numbers had not been flagged as high-risk countries, so that we pay special attention to those people. So we started debating to close the airport, to close the borders. When we were still debating, we had our first case detected at the airport. And that was between the day we had decided we were closing the airport and the 24-hour announcement, which is a requirement for international air travelers. We got our first case, and we realized that we were actually we went really fast. We identified that one of the countries we had thought was not high risk was actually giving us a lot of travelers. One of them was your airport, because everybody seemed to be going through Uganda. Airlines which were bringing, which were sending bombardiers were now sending Dreamliners. So travelers through the airport became so much. And in that process, we also got quite a lot of cases. One of the things we learned is that that you have to think through everything seriously. Because we said, okay, Ugandans can come in from everywhere that's there. And that is how the virus got introduced in the country. But because of the surveillance system, which education went on and people began to understand, even some people who had escaped, because we put them in quarantine and they escaped from quarantine. They bribed the security people and got out. But when we called them back, they came back, turned out to be important. So one of the things that has really worked well in Uganda is the surveillance system, the ability to track people, to track those who had traveled, and the ability to track their contacts. Some of the contacts became positive, but we have followed up the chains and they have not turned out. We had like 2 contacts per 2 contacts who became positive. So we have this surveillance system is an existing surveillance system we have built because of our vulnerabilities. The other experience with Ebola, we have healthcare workers who really know how to work in infectious environments. So to date, we haven't had infection. The third thing which I've seen in Uganda, and which has made a big difference, is the engagement of scientists. I've not had the epidemic.
Dr. Monica, I think your connection is cutting out and we are near the end of our session. So I think we're going to have to stop there for your comments today, but they have been incredibly helpful and are very much appreciated. I'd like to very briefly go to Dr. Mazet for any closing comments and Dr. Bazeyo to go ahead and wrap us up for today. And I want to apologize to a few of the panelists who had offered to share thoughts and we just didn't get the time to do that today. So on our next session in 2 weeks, if you're able to join, then we will go ahead and start with your thoughts on what's happening with COVID-19 and also on the gender and psychosocial aspects that are coming up as a focus topic for the next session. So we can do a bit of a hybrid if we would like to. Dr. Mazet, any closing comments you would like to share with the group based on what you've heard?
No, I just think it was really wonderful detail and examples, and thank you so much for your participation. Thanks to the ECHO team, and I will hand it over to my partner, Dean William Bazeyo, to wrap it up.
Thank you. Somebody had muted me and they didn't allow me. I want to thank all the participants, and I want to thank and applaud the Kenyan country manager who gave us a lot of detail, and it was very clear for all of us. It was very great. But I want also to call upon the scientists that we need to help our countries, our leaders, when they're making decisions. One thing that Irene mentioned, and I think I want to reiterate it, that the president of Uganda drew in scientists, especially those from the university, from Mekelle. We know that about 60% of the people in the task force are from the universities, 60 or 70%, which made a lot of difference. And it's unfortunate that some of the countries are drawing in scientists from universities late, and they are believing on advice from people who are not dealing with science closely now. But we hope that they will learn from the experience of the neighbors. I want to thank our US partners for your continued support. And as I said, I think to Watrina, these sessions, whoever thought about them, this was a great innovation for this coronavirus pandemic. And I thank you, Jonna, with your team. This has been great. And I think when I look at the participants, I see more than 200 every time, and they carry back all the information. Thank you very much. And all of you, thank you once again, and we meet again in 2 weeks' time.
Thank you so much, everyone, for being together. Have a good evening, have a good day, and we will look forward to talking to you very soon. Follow-up information will be posted on the webpage for the FAQs, as well as the recording links. And then I think Bruce may put up the end QR code if people would like to scan it, if they're able to use the PDA. I know many of us are trying it out, and if there are some glitches, let us know that too.
Thank you very much.